Welcome to Pulse and Pressors, where critical care gets crystal clear. Today we will discuss the TAVR procedure. From the femoral groin pathway to valve deployment, the test that proves success, and post-procedure management. Who gets a TAVR? Patients with severe symptomatic aortic stenosis. While it began for prohibitive or high surgical risk, it's now common in intermediate and selected low-risk patients after a heart team evaluation and meticulous CT sizing. We avoid TAVR when anatomy is hostile or unfavorable, coronaries are too low, infection is active, or non-cardiac disease limits meaningful survival. Planning depends on the CT and sizing. We size the annulus, map leaflet calcium, check coronary heights, and vet the iliofemoral root, diameter, tortuosity, and calcium. Transfemoral access is preferred. Alternatives are reserved for hostile femorals. Valve platform, balloon expandable or self-expanding, drives sheath size, paravalvular leak tendency, conduction risk, and deployment style. In the lab, we place a large-bore femoral arterial sheath for delivery, a contralateral pigtail for root angiography, and a temporary right ventricular pacing wire. We ensure anticoagulation meets ACT targets. We keep tight hemodynamic control with an arterial line and venous access. To deploy the valve, the stenotic aortic valve is crossed and, if necessary, predilated. The crimped bioprosthesis is then advanced and precisely aligned within the annulus. Rapid ventricular pacing is initiated to transiently reduce stroke volume and stabilize the valve position during deployment, preventing it from being displaced by ejection forces. After deployment, valve function is assessed by injecting contrast dye to confirm proper seating and to ensure there is no paravalvular or transvalvular regurgitation. We will expand on this in the next few slides. This is the pathway for the TAVR delivery system from the common femoral artery and follows a straight arterial pathway to the aortic valve. Common femoral, external iliac, common iliac, distal abdominal aorta, descending thoracic aorta, aortic arch, ascending aorta, across the native aortic valve into the annulus for deployment. The prosthesis is positioned under fluoroscopy and echocardiographic guidance, typically with rapid ventricular pacing during release. At the same time, we place a pigtail catheter from the opposite groin into the aortic root. This contralateral pigtail is used to inject contrast for root angiography before and after deployment. The angiogram confirms valve depth and orientation, verifies coronary patency, and evaluates for paravalvular leak. If there's underexpansion or significant paravalvular leak, we can perform post-dilation. Once imaging confirms a stable result with none or only trace paravalvular leak, we secure hemostasis at both groins and proceed to intensive care unit level care. Proving the win means aortography and echo, confirm position, coronary patency, and aim for none or trace paravalvular leak. If underexpanded or leaking, we post-dilate. Then we reverse heparin if appropriate, remove the large-bore sheath through the pre-closure device, and achieve hemostasis. Once in the intensive care unit, most patients stay flat 2 to 6 hours after sheath removal, depending on closure device and unit or hospital policies. We scrutinize the groin for bleeding or hematoma and confirm distal perfusion by performing frequent groin checks and distal pulse checks. Administer renal protective IV fluids as ordered. Anti-thrombotics commonly default to single antiplatelet therapy unless AFib or other conditions require anticoagulation. Hemodynamically, we target a map of 70 to 90 unless the MD sets a different goal. Too low suggests bleeding, tamponade, or significant paravalvular leak. Too high stresses the access site and raises stroke risk. For post-TAVR hypertension, our first-line agents are calcium channel blockers, like Clevaprex. They offer smooth, arterial-selective afterload reduction with fast on-off kinetics and minimal AV nodal depression, which matters because new conduction disturbances are common. In the first 24 to 48 hours, we avoid beta blockers as routine antihypertensives. New left bundle branch blocks, PR or QRS widening, and intermittent high-grade AV block are not rare, and beta blockade can worsen bradycardia or AV block, or obscure evolution to complete heart block, especially dangerous if the patient had pre-existing right bundle branch blocks. Conduction is the wild card. Expect new left bundle branch blocks PR and/or QRS prolongation, and intermittent high-grade AV block, particularly with deep implantation, bulky septal calcium, or certain self-expanding valves. Keep the temporary pacing wire for 12 to 24 hours if there's any new conduction disease. A left bundle branch block can develop because the TAVR valve frame sits right against the membranous septum, where the His bundle and left bundle branch pass, making them vulnerable to compression and conduction block. If a patient has pre-existing right bundle branch block and develops a new left bundle branch block after TAVR, that bilateral bundle disease carries a high risk of complete heart block. Plan for a permanent pacemaker unless electrophysiology guidance says otherwise. Persistent or recurrent high-grade AV block is also an indication for permanent pacemaker. There's a physiology you must name at the bedside: suicide left ventricle, dynamic left ventricular outflow tract obstruction after we relieve fixed aortic stenosis. A small, hypertrophied, hyperdynamic left ventricle, often with basal septal thickening, develops systolic anterior motion of the mitral valve and a venturi-driven outflow gradient, causing hypotension and acute MR. Management is the opposite of low-output pump failure. Fill the ventricle with fluids, raise afterload with phenylephrine or vasopressin, and use a short-acting beta blocker like Esmolol to reduce contractility and heart rate. Avoid inotropes and vasodilators here. They steepen the left ventricular outflow tract gradient. If needed, dual-chamber pacing can alter septal activation and reduce obstruction. If the patient remains unstable and refractory to initial therapy, we escalate quickly. Right ventricular pacing, temporary or permanent, can induce atrioventricular and left ventricular desynchrony, altering septal activation in a way that reduces the dynamic left ventricular outflow tract gradient. Alcohol septal ablation, TASH, involves targeted alcoholization of a septal perforator to thin the basal septum and relieve obstruction, adapted from HOCM therapy. The idea is to scar a small, strategic section of the thickened interventricular septum so it thins and stops obstructing the left ventricular outflow tract. Veno-arterial ECMO, a last resort bailout for refractory cardiogenic shock, bridging to definitive therapy or myocardial recovery. Early recognition and prompt initiation of these pathways are critical to survival. You'll also see cardiothoracic surgery on standby during TAVR. That's not ceremonial. It's because catastrophic complications demand immediate surgical bailout: annular or root rupture, aortic dissection, coronary obstruction, valve embolization, or refractory bleeding or tamponade. Cardiothoracic surgery also enables rapid conversion to open surgery or emergent mechanical circulatory support if needed. Next day echo locks in the result: mean gradient, valve area, paravalvular leak, pericardial effusion, and left ventricular function. Mobilize once the groin is quiet. Continue DVT prophylaxis. Discharge when rhythm and blood pressure are stable, renal function acceptable, neuroexam clean, and the patient understands site care and home blood pressure and heart rate monitoring. Red flags you can't miss: sudden hypotension or back pain. Think retroperitoneal bleed, hypotension with neck vein distension, tamponade, chest pain and instability, coronary obstruction, acute neurochange, stroke or TIA, oliguria or rising creatinine, contrast-associated AKI. Match the treatment to the cause and escalate early. This is Pulse and Pressers, reflecting on the marvels of the human body. Subscribe to stay sharp and tell us in the comments what you want to see next.